Cordial saludo, mi nombre es Jaime Sosa Moreno, yo soy médico residente de alergología clínica de la Universidad de Antioquia y hoy, por idea del doctor Ricardo Cardona, que es nuestro jefe de programa, queremos hacer una invitación para el público extranjero. Queremos comenzar a hacer unas exposiciones en inglés, esto con el fin de limitar las barreras que el idioma causa en el conocimiento, y esperamos que esta conferencia sea de su agrado y que tengamos muchos seguidores de otras ciudades y de otras partes del mundo. Okay, as I was telling you, my name is Jaime Sosa Moreno. I am medical doctor. I am clinical allergology resident here at Universidad de Antioquia in Medellin, Colombia. And this is the very first time we are going to do an English conference. This is an idea of Dr. Ricardo Cardona. He is the head of Department of Clinical Allergology here at Universidad de Antioquia, and he is looking to remove the language barriers to have more people interested in our specialty. So we are looking to have people from other parts of the world, and you are very welcome. I hope you enjoy this conference. And today we are going to talk about the Global Initiative for Asthma, the GINA, and what's new in the GINA 2019. They have done some updates, so we are going to talk about them today. So we should start talking about a little bit about the background of asthma. The asthma is not a weird pathology. Asthma affects almost 339 million people around the world, so it's a very common pathology, and this shows us that we have to know the management, and we have to be clear in in the way we are going to treat our patients. It is so important because almost 1,000 people die each day from asthma. So we have to have our patients in optimal condition and with the optimal treatment to prevent these exacerbations and these catastrophic events. The asthma has been catalogued as top 20 causes of years of life lived with disability in the world, and we have had two distinct peaks in early mortality in asthma. The first one was in the 1960s, and it was due to the introduction of a new inhaler that was isoprenaline, and it had some cardiotoxic events. And the second one was in the 1980s, and it was due to the introduction to another inhaler that was lava, and that was the phenobarbital. And the phenobarbital was used in very high dose, and it leads to cardiac toxicity. We should start redefining some paradigms. Remember that the inhaled SABA has been the first line treatment for almost 50 years. And we have to open our minds, and we have to change this paradigm, because today we have some evidence that is showing us that the frequent use of SABA is leading to catastrophic events in our patients, and is increasing the mortality rate of this patient. So we are going to talk today about the evidence that is available and that shows that the use of SABA is detrimental in our patients. So remember that the mild asthma includes the intermittent and the persistent asthma, and it affects between 50 to 17% of asthmatic patients. And mild asthma is more frequent, is more severe, and is more symptomatic and less well controlled in children than in adults. So we have to take this into account, because severe exacerbations in mild asthma represents almost 30 to 40% of asthma exacerbations, and these exacerbations are requiring an emergency department consultation. By other side, remember that 30 to 37% of adults with acute asthma and 16% of patients with near fatal asthma and 15 to 20% of adults that are dying from asthma had symptoms less than weekly in the last 3 months. So this talk about the control of asthma. We need optimal control of asthma in our patients, and our patients, because our patients may have almost great control, but remember these percentages of patients that are presenting with severe exacerbations, and they have less than weekly symptoms in the last 3 months. So we have to be alert about this. So let's talk about the regular of the or frequent use of SABA. Some studies have shown that this is detrimental to our patients. And the pathophysiology of this is because the frequent use of SABA is associated with the beta receptor downregulation. The patient has decreased bronchoprotection and has rebound hyperresponsiveness. It has decreased bronchodilator response, and this is associated with the frequent use of SABA. The patient is going to have also increased allergic response, is going to have increased eosinophilic airway inflammation. So we have the clue question in the GINA is the reliever needed more than twice a week? So this question is talking about the frequent use, and as you can see, a frequent use is very easy to achieve if you are talking just about more than twice a week. So a lot of patients are in this group of patients that is using ASABA in a regular basis and is going to have more detrimental outcomes because of the use of the SABA. So we have had some studies that show relevant information and evidence that the higher use of SABA is associated with adverse clinical outcomes. I want to show these two studies. In the first one, they found that the use of more than 3 canisters per year, that is just an average of 1.7 puff per day, is associated with higher risk of emergency department consultation. And they found also that more than 12 canister per year is associated with higher risk of death. So we have to be aware of these because also we have higher risk of death in our patients. So the GINA got some update purposes to show people and to show clinics and to show physicians that the treatment of asthma has to change. We cannot have in our minds that the step one and the reliever is going to be SABA anymore. So they got this evidence, and GINA had really important update purposes, and those were some of the most important of the 2019 updates. So the first one, they were looking to reduce the risk of asthma-related exacerbations and death. The second one was to provide consistent messaging about the goals of asthma treatment and including prevention of exacerbations and across the spectrum of the pathology that, as you know, is a very wide spectrum. And you can have mild asthma presenting from one to another color or phenotype in a patient with the same genotype of another one. So, and the last one was to avoid establishing patient reliance on SABA early in the course of the disease. So we don't want to have our patient with a recently diagnosed asthma just treated with a SABA. So we are going to talk a little bit more about the evidence that GINA took into consideration for making these changes. So the first study was the Sigma 1, and the Sigma 1 talked about the inhaled combined budesonide formoterol as needed in mild asthma. So we have in methods a total of 3,849 patients that underwent onto a 22-week double-blind trial that involved patients from 12 years or older with the diagnosis of mild asthma. And the patients were randomly assigned into three different groups. The first one was twice daily placebo plus sertraline, that this sertraline was used as needed. The second one was the twice daily placebo plus budesonide formoterol, and they used 200 micrograms of budesonide plus 6 micrograms of formoterol, and this was used as needed too. And the third group was twice daily budesonide, and this they used a 200 micrograms regime plus sertraline that was used as needed too. So the primary objectives of this study was to investigate and to assess the superiority of as needed budesonide formoterol to as needed sertraline with regard to electronically recorded weeks. So every patient has a diary that was an electronic diary, and they were asked to just check the weeks of well-controlled asthma. So we can see here the overall weeks of well-controlled asthma. As we can see here in gray color, we have the budesonide maintenance group that was a regimen of 200 micrograms budesonide. We have in red the budesonide formoterol as needed group, and we have in blue the sertraline as needed group. So we have here that the budesonide formoterol that was used as needed was a little bit inferior to budesonide maintenance therapy regard to the percentage of electronically record of weeks that were well controlled. So, but the treatment effect in these two groups was similar in subgroup 1 and subgroup 2. Regarding the time to first exacerbation, we got that budesonide formoterol use as needed prolonged the time to the first exacerbation when compared with the sertraline used as needed. We have a hazard ratio of 0.44. We have here in blue color the sertraline as needed group, and we have here in red color the budesonide formoterol group. So we can see that the patients used that were using budesonide formoterol as needed had a prolonged time to the first exacerbation. Most important, the results in the budesonide formoterol group did not differ significantly from those in the budesonide maintenance group. So we can see here that the budesonide formoterol versus the budesonide group is very similar in this outcome that was time to first exacerbations. And another important data was the rate of discontinuation of the therapy, and the rates of discontinuation of the therapy was higher in those patients that were using sertraline, but the patients that were using budesonide formoterol as needed therapy, they had greater adherence to the treatment. So in the results, we have that as needed, budesonide formoterol provides superior asthma symptom control, but was inferior to the budesonide maintenance therapy. We have also that the exacerbation rates with the two budesonide regimens were similar and were lower than that the rates of the sertraline therapy used as needed, and the budesonide formoterol used as needed result in substantially lower glucocorticoid exposure to these patients, and the dose were really lower. They talk about just a quarter of the dose, was like 17% of the dose in the budesonide formoterol group versus the budesonide the budesonide alone as a maintenance therapy. And we have also the Sigma 2 trial, and the Sigma 2 trial was as needed budesonide formoterol versus maintenance budesonide in mild asthma. So we have here a total of 4,250 patients that underwent into a 52-week double-blind trial involving patients 12 years of age or older with diagnosis of mild asthma. And these patients were randomly assigned into one of two groups. The first one was patients with twice daily placebo plus budesonide formoterol. They use also 200 micrograms of budesonide and 6 micrograms of formoterol, and this therapy was used as needed. And the second group was the group that uses just budesonide as a maintenance therapy, and they use twicely 200 micrograms plus terbutaline that was used as needed. And the symptoms were assessed using the scores of ACQ-5. So we have in the budesonide formoterol used as needed was not inferior to twice daily budesonide with respect the rate of severe asthma exacerbations during all the trial, the 52 weeks. And the patients in the budesonide formoterol group had just one quarter of the glucocorticoid dose exposure. So these patients really have just like 15 to 17% of the glucocorticoid dose. So regarding the forced expiratory volume in 1 second before the bronchodilator use, we have here the two groups. The black colored is the budesonide maintenance group, and the red color is the budesonide formoterol as needed. So remember that this is an indirect measure of the lung function, and the approximate minimal clinically significant change in the BEF1 is not well established, but it is around 100 to 200 millimeters. So here we have both groups, and we have the group of budesonide formoterol, a change of 104 millimeters, and we have the budesonide maintenance group in a change of 136 millimeters, and this is a difference just of minus 32.6 millimeters. Regarding to the asthma control questionnaire ACQ-5 scores, we should remember that this is a score that consists about 5 questions about the asthma symptoms in our patients in the previous week, and each of which is scored on a range of 0 to 6 is the maximum impairment. But we have to take into account that important differences are between 0.5 to 1 units. So we got here the both groups, and we have the budesonide formoterol in red, and we have the budesonide maintenance group in black, but we have here the change from baseline in the ACQ-5 scores, and we can see that in both groups the change was inferior to the significant change that we were looking for. In the first group, we got just minus 0.35, and in the second group, we got just minus 0.46. So there were no significant change between both treatments. So as a conclusion, these two studies demonstrate that as needed treatment with budesonide and formoterol prevented exacerbations and loss of lung function, and significantly reduced the median daily ICS dose. Remember that was just the 15 or 17% of the total dose of the budesonide maintenance group. But remember that these patients, this treatment, was less effective than other treatments for symptom controls. remember that GINA wanted to show the emphasis on personalized treatment, and that treatment doesn't mean just medications. We have to look also about treatment of modifiable risk factors in our patients and comorbidities and non-pharmacological strategies too. So remember to assess, adjust, and review the response, then to have symptomatic or symptoms control in our patients, including risk factors. Then we have to treat the modifiable risk factors in our patients and got some emphasis in a non-pharmacological therapy. And the last point, we are going to talk about the asthma medication options here. So remember that we are going to start with the step one, and the step one is for patients with symptoms that are less than twice a month and with no exacerbation risk factors. So we should start with the first paradigm that we talked at the beginning of our conference, and GINA no longer recommend the SAVA-only treatment, and this was changed because of the evidence that I just showed to you. And remember that the SAVA-only treatment increases the risk of a severe exacerbation, and adding any ICS significantly reduces this risk. And this decision was based on evidence that SAVA-only treatment increases the risk of severe exacerbations, and adding an ICS therapy reduces the risk. So remember that all adults and adolescents with asthma should receive symptom-driven or regular dose ICS therapy that contain a controlled treatment. And this is established just to reduce the risk of serious exacerbations. And remember that the short-term clinical benefit may not be necessarily seen in every patient that we treat, but we have the aim to reduce the probability of serious adverse events at population level. We have here this dotted line around the step one, and it indicates that the evidence is indirect. So we are going to talk about that deeper here. So we start with as needed low dose of ICS for Moterol, and this is an off-label therapy. We have some indirect evidence from Sigma 1 and Sigma 2 studies that were the studies I just explained to you. And we have the reduction in severe exacerbations versus SAVA-only treatment in patients that were eligible for the step 2 therapy. So they were looking some values and preferences, and they were the high importance of given to reducing exacerbations, the high importance of given to avoiding conflicting messagings about the goals of step 1 and step 2. They took into consideration also the high importance of given to poor adherence with regular ICS in patients that had infrequent symptoms, and these patients were so exposed to SAVA-only treatment. So these patients were at increased risk of severe exacerbations because of the use of SAVA-only treatment. We have other therapies. The other therapy is the low-dose ICS taken whenever the SAVA is taken. This is also an off-label therapy, and the evidence is also indirect. We have evidence from different studies in patients that were eligible for step 2, and this was these studies, the BEST, the TREX, and the BASALT, and we have some values and preferences, and they got some high importance given to preventing severe exacerbations, lower importance given to small differences in both groups, and the inconvenience of having 2 inhalers because these patients had the two inhalers, that was the ICS and the SAVA inhaler, and they they talked about the combination of ICS SAVA that were available in some countries but were only approved for maintenance use, as happened in our country, that we have the combined therapy, but it's only approved for a maintenance therapy, not as a reliever. So we have to use these medications off label. So remember that the daily ICS is not longer listed in the step 1. We start here with the step 2. In the step 2, we have daily low dose of inhaled corticosteroid or as needed low dose ICS for moderate. So we have the evidence that regular low dose ICS with as needed SAVA. We have a large body of evidence of RCTs that and observational studies that show that ICS substantially reduce the risk of exacerbations, hospitalizations, and deaths. And we have that serious exacerbations halve even patients with symptoms 0 to 1 day per week, as I started the presentation telling you that the patients with severe exacerbations and higher risk of death hadn't had any symptom for a week for the previous 3 months, and they were also looking for improved symptom control and reduced exercise-induced bronchoconstriction. And we have also as needed low dose of ICS for moderate as an off-label treatment, but remember that all the evidence was showed with budesonide for moderate regimens. So they just tell us we can use or we could use an ICS for moderate, but remember that the ICS that showed evidence was the budesonide. And we got this evidence, we got direct evidence from 2 large studies of non-inferiority for severe exacerbations in these patients that used daily low-dose ICS plus SAVA versus as needed SAVA. And we got direct evidence from 1 large study that showed a reduction of 64% in severe exacerbations versus SAVA-only treatment. We got also 1 study that showed reduced exercise-induced bronchoconstriction. As other controller options, we have the leukotriene receptor antagonist, and we have low-dose ICS taken whenever the SAVA is taken. So let's start talking about the low-dose ICS taken when the SAVA is taken. This is an off-label treatment too, and remember that the patient has to use 2 separate inhalers if he's going to use the ICS whenever the SAVA is taken. But remember that we have the combined option too, but because of some country regulation in some regions, we have this combined therapy just for maintenance and not to use as a reliever. So we got the evidence that, and we have 2 RCTs that showed reduced exacerbation compared with SAVA-only treatment. We have the best trial that was that underwent in adults with combination of ICS-SAVA, and we have the TREXA study that was undertaken in children and adolescents with separate inhalers. They used a SAVA inhaler plus an ICS low-dose inhaler. And we got also 3 RCTs that showed similar results or fewer exacerbation compared when they compared the combined therapy to the maintenance ICS. Finally, we got some changes in GINA 2019 regarding to children from 6 to 11 years old. In 2019 GINA, there is a separate treatment figure just for children, rather than differences being handled with footnotes as in the past. So here we got a box that is just for children aged 6 to 11 years, is the box 3 5B. So in step 1 treatment, we got a low dose ICS whenever the SAVA is taken. And remember that this is indirect evidence, or we could have to reach the same control with daily low dose ICS. In step 2, we have that the preferred controller is daily low dose ICS, or we have other controller options that include as needed low dose ICS taken whenever the SAVA is taken. But we got just one study in children. In the step 3, we got low dose ICS LAVA and medium dose ICS are preferred controller treatments. And in step 4, remember that we should start referring the patient for expert advice. And the preferred treatment is going to be the medium dose ICS LAVA. And as a final part of this conference, we have some conclusions and future work. Remember that the combined therapy seems to be a good option as a controller and reliever in patients with mild asthma. Remember to be aware of patients and reach optimal control with 0 symptoms, because patients with severe outcomes had symptoms less than weekly in the previous 3 months. Remember that as needed low dose ICS for moderate showed direct evidence of a 64% in reduction in severe exacerbation when compared to a SAVA-only treatment in patients with mild asthma. So every time we are looking or having a patient with in a step 1 that is just with SAVA-only treatment, we should change our mind and make up our mind and change this treatment, because we now get direct evidence that shows that these patients are gonna be in a higher risk of severe exacerbation, including death. And last, we have that the SAVA-only treatment increases the risk of severe exacerbation, and it is not longer recommended in step 1. So these are our conclusions. I hope you enjoy our conference, and you are very welcome to follow us and to join us in our channel. If you have any question, you are welcome to ask us. Thank you very much.